One. So to begin with, I would request Dr. Dhruvi, what do you think about, or how will you help us imagine the supportive ecosystem for children with type 1 diabetes at a tertiary care level?
So thank you, Mahira. Since time we started training together at Diacare, we've always imagined that there is a sphere wherein people can live without the prejudice of being called patients. That's number one. And in spite of whatever we do, even in my previous talk, I kept telling people with diabetes, still they are called patients. So that's number one. Some place wherein all of us, without the aspect that I am the main person in the treatment of diabetes. No, we are not the main people for the treatment with diabetes. It's that child, it's that person with diabetes who's the main person. So an ecosystem where that person is recognized well, and we all work together in synchrony for that person rather than, ourselves. So that's the ideal ecosystem I would imagine as.
Okay. Thank you. I agree with that. And coming to Dr. Rutul, what do you think at a tertiary level, one thing that can help us improve our ecosystem, how can we improve so that to improve the outcomes of children?
So this is very important question as ecosystem. For making any ecosystem, we have to include everyone. And this is the type 1 diabetes, I would say, is not a disease of a person, but it's a disease of family and a community sometimes. So why community? Because for type 1 diabetes, the biggest thing is support system. And for support system, we should include all the members, including family members as well as the vicinity. Even the friend who is there with the child in the school, or even someone where the friend who is playing at the playing ground, the patient or the kid is having this friend who should be also knowing each and every aspect of type 1 diabetes, especially hypoglycemia, which is the emergency condition in most of the cases in type 1 diabetes, when it is persistent hyperglycemia and that also hypoglycemia unawareness. In such condition, this ecosystem should be built, and they should be more and more encouraged through a different source of platforms like this conference, as well as different webinars that we do, the different programs that we do along with such kind of community. Even the parents who are taking part, as Savita ji is here, who has made such a wonderful platform of Juvenile Diabetes Parent Foundation. Ideally, we should take support of each and every person in our vicinity.
Okay, thank you. I agree with that. Now coming to Komal ma'am, having the experience at public level field, what do you think an ecosystem should look like at our Indian scenario at the primary care level?
So I think clinical setting, what I think Dr. Dhruvi, Dr. Rutul mentioned, from a public health side, two major pillars of our entire care system. It's inclusivity and equity.
Okay.
So we should not make them feel biased or make them feel that they're different from the system, number one, and equity. So everybody should get an equal chance to get the treatments, get the consultations, and like education, physical activity related things. So they should be included in everything. They should not feel specialized in different ways, and equity opportunity. So the treatment care should reach to the last mile.
Agree very much.
That has to be there, and for that larger level of advocacy has to be needed. So we need to make this policy makers hear that there is a voice from these kids and from these families, and it is must for us to look into that, because they are our future. Any investment that we make into the pediatric population or into our children, that will define shape of our country.
Right.
How we look at the things.
Right. And Savita ma'am, would you help me answer that? You are looking after Juvenile Diabetes Parents Foundation, and we are talking about inclusiveness. So are there any gaps at the rural level where you have witnessed still the things are not well, and how we can help them improve those things?
Yes, thank you, Maida. Thank you, Rutul sir, for your kind words. Thank you, Dhruvi ma'am. So definitely inclusivity is one thing. So apart from the formal part of it, I think it should start from home also. like, with the siblings. There, the kid with diabetes should be made to feel inclusive. And what I did with my daughter was I made her independent from day one. That was my first decision. For that, I connected with other parents who are going through the same situation as mine. And we took the mode of education through doctors. At that time, we did not have diabetic educators, but now we have that field. So I think a diabetic educator is a bridge between the doctor and the parent. So that is one field where, we can add up and help parents about it. And everything then goes in the course of pre-planning. Like till date, we always prefer pre-planning for every small or big decisions. And since childhood, since my daughter was involved, so that's the case till now. Every small to big decision about her health, she's been inclusive in it. So yes, inclusivity from home, definitely. Thank you.
Thank you. I agree with that. Now, the other part of, I feel, pediatric diabetes is data. Data numbers can change the game. So coming to Komal ma'am, we hear often that, absence of data in our country and in Gujarat. So what steps can we take to improve our data and generate the meaningful scientific evidence out of that?
So what a fantastic question, especially when we see impact, like how policy decisions, programs are being made. So for that, we need to have core data set from our population itself, telling us about the burden, telling us about the cost implications, telling us about health systems need in this area. So of course, I buy that we do not have a very concrete data sets which can give us a picture, region-specific picture in our own area about type 1 diabetes. So we have started couple of initiative, and a lot of other colleagues have started couple of initiative. So the first initiative is the landscape assessment. Like, let us have a landscape of assessment right from the GLAIR literature, right from the hospitals, clinics which are gathering this data, validate it through roundtable discussions with the stakeholders who are gathering this data set. So this is what we call as qualitative assessment. So which might not have concrete number, but which will give us a ballpark figure that this is what is the picture in our region. So you always have two choices. Whether you go ahead with a global data set, which are very well established, but they are not from your own context. And the second is relatively crude way, but that will give you a very contextual evidence that this is your data.
Okay.
So we have started doing it, and a lot of other a lot of other states have also started doing it. So data, now we have ballpark figure. We have also started to bridge the gap between public and the private body.
Agree.
So system is also having their own data set, and our private practitioners, they also have their own well-established data set. So we're trying to bridge that gap so that we get a holistic number. And the third and the most important thing when we talk about data in terms of sustainability. So we are trying to develop a portal or a platform with the state itself where they can actually digitalize the patient's record wherever they are coming up. So in the mainstream system, if those patients are being notified, recorded. So 5 years down the line, I think we'll have our own solid data sets.
I hope so.
Definitely.
I very much hope so. Now, to Dr. Dhruvi and Dr. Rutul, what do you think at a tertiary level, how can we improve our data set so that it can be analyzed and results can be generated?
So I'll give my first answer to this, that it is a tough task to get people working for diabetes together to collect a data which is unified in the formation in a single format. For all our audiences, when we are talking about pediatric diabetes, we are now not just talking about type 1. We are also talking about other forms of diabetes happening in kids. We are also talking about type 2 diabetes happening in kids. But per se, the majority of kids impacted by diabetes is the type 1 population. And that is why we always come back to talking about what happens in kids is associated with type 1 diabetes. I'll come back to your question. And even the four of us sitting on this very same platform, it has taken me 5 years still, and we've not come to a concrete format that we collect the data of all our people with type 1 diabetes in the same way, so that somehow we benchmark our
Own data.
outcomes. We benchmark that, maybe doing some format of intervention, or the GCP that Savita ji might be doing, Komal ma'am can analyze it and then tell it to Rutul and myself that, maybe what she's doing, you can change it in your practice and,
Agree.
bring about a change. So yeah, over to you, Rutul. What do you say about it?
So basically, what Komal ma'am said is really true, that we are seeing the change, but still I strongly feel that we need registry for type 1 diabetes, and that should be state level or national level, whatever, as you are working for it, but we are not seeing that straight
Results.
work. Yes, results as well as, no, results she is saying that we'll see after 5 years, but registry level work, still we are not seeing, and except you, no one is approaching us for this thing, and this is very sad part on state level, and we need it badly, as what we are seeing the future. Recently the data is coming for cell-based therapy, stem cell-based therapy, or even disease-modifying therapy. This all will depend on the data, and the patients who are going to get benefit, or the siblings who are going to have type 1 diabetes in future or not, this all will depend on data, and data that we need to get as soon as possible. And we should have a registry including antibodies as well as genetic tests should be included. I feel that to prevent type 1 diabetes, we need this, and this will be future in next few 5 or 10 years, but for that we need data.
So in the same line, ma'am, what is your vision of establishing a national registry? And you have the experience of establishing one in cardiovascular. So a long-term vision in establishing type 1 diabetes registry.
So I would say more voices and more advocacy.
Okay.
So before that, like until unless we reach to that level, it is exceptionally a tough task to get everybody on the same board. But meanwhile, the system strengthens itself. What we can do, what we have already started doing, sit together with the like-minded people and show them the example that this is how this can be done. Until unless we come up with that, it is very difficult to shake that entire thing and make our voices heard.
Right.
But the light at the end of a tunnel is now you sit in any of the national roundtable meetings or there, type 1 voice is being heard.
Yes.
Somewhere down the line, when we are working with all the pediatric NCD, type 1 voice is heard and in a very strong manner.
Yes.
And now India is approaching towards what we call as evidence-supported policy decisions. So that's why it is very much instrumental to generate our own data, streamline it all, and then come up with our own guideline and recommendation. So yeah, we see the hope, and the only plus point is we need to sit together and start working,
Right.
show them that this is how this can be done.
Very much agree with that. Now, I feel the other part of ecosystem is training the trainers. You know, when we started, even we had a limited knowledge, and we grew up where, you know, we gained knowledge. So I would ask Dhruvi this question: what do you think? How we can, or training the even healthcare professionals in the ecosystem, coming, you know, inviting them to this ecosystem.
So this is our own platform, and I'll be very straight and blank honest. It's
can.
very tough to tell people you don't know anything about
No,
type 2
not about
diabetes.
anything. It's like, you know, knowledge is that thing you can learn at any stage. It's not like you do not know, but let's take it that way.
But not many doctors or HCPs come forward and say that, you know, I have inadequacy of knowledge. And even when you have a panel like this or sessions like this at conferences, there is lesser participation because people feel, you know, that it's lesser in prevalence and it's something extra. Rather, I would refer the person or I'll do whatever I can read in a couple of pages. So yes, advocacy is important. Training of HCPs is very important. But getting to them, I still am not sure, other than conferences, panels, or even like people, unless they approach you that, you know, I am an HCP interested in learning more about type 1 diabetes. I don't think we can go and tell them that, you know, we are here. Yeah.
So in this point, I would definitely be agree to Dhruvi that insulin is definitely a boon to us, but in some point it has become curse. As I have seen that for whether it is GDM, whether it is type 2 diabetes or mainly type 1 diabetes, no doctor wants to treat patient whom you want to start insulin. So in pediatrician, ideally it is their job to start at least insulin, basal bolus insulin. They all must know, but we are seeing that they are not starting it. They are sending it to physicians or endocrinologists, pediatric endocrinologists, so they don't want to treat it. anywhere we want to start insulin, it is becoming a problem. And this is why we all should learn, and everyone in this room should take a pledge to learn type 1 diabetes better, as we need to support them more and more. And whatever we are seeing every day in clinical practice, it is very different from what we are talking here. Basal bolus insulin, giving this insulin is it doesn't suffice, and we need more and more and more education. Though we have so many advocacy groups, we are seeing every day there is one or another program on mental health, on psychiatric disorder related to type 1 diabetes, basal bolus therapy. There are multiple problems in type 1 diabetes. We are addressing it, and we are having so many advocacy groups. They are working so hard, but and still we are not reaching at the point where we should reach, and we should be heard clearly at national level and our state level government, and they should start from their side only.
Agree with that. Yes, please.
I'll tell you a very anecdotal thing. I delivered a lecture on type 1 diabetes and pregnancy at one very huge conference. And my chairperson, who was a very senior physician, he told me, chalo, pregnancy mein to you'll give insulin, but what before and after that? This is the level.
Yes, we need to know that scenario. That is the thing, and where the training can start. Okay, so Savita ma'am, as said, we have enough of insulin. So can you help us answer this? Like, what are the fear and misconceptions prevalent? Abhi bhi dikh raha hai. What are such fears and misconceptions among patients?
So primarily, I would say that when the child is diagnosed with type 1 diabetes, they go to a doctor, and some doctors are yet prescribing mixed start to type 1 kids. When they come to us and we shift them to basal bolus, then they feel नहीं वही डॉक्टर अच्छा था जो दिन में 2 बार दे रहा था, ये तो दिन में 4-4 5-5 बार बोल रहा है. तो वो डॉक्टर शॉपिंग चालू होती है, एंड देयर इज द फर्स्ट प्लेस वेयर वी फेल, कि उनको दे वांट दैट डॉक्टर जो 2 बार दे रहा है. When the health is compromised after a year or 2, then they again come back. They understand. So, as everybody said, education, maybe in the regional languages, creating more diabetic educators, or maybe one at every clinic who can give good dedicated time, and that will definitely help. So regional language is also one thing that would help us to reach the parents.
I agree with that. And my last question to Komal ma'am. Ma'am, what do you think? How can we, we already have the government system, ABHA, where e-Sanjeevani things. Do you think that can help us somewhere to inoculate the type 1 diabetes thing into that?
So first, maybe the journey is long, the road is
Really
long. Definitely, because I sit with them, so I know that how do they think? How do they think they have priorities, and how do they assign budgetary things into all of this? How do they do that task shifting and all? So definitely with our ID and digitalization, we are going to see a better care, better tracking of these patients. Like what we have already started and recommended them, that you integrate this into their current system. So RBSK is there, NCD portal is there, where every child is being screened, where that data goes. So that is there in the register. So we are now doing the advocacy that you digitalize this register so that you can track those patients. So the talks are on. We need to show them that this is how this can be done. And the good thing is some of the state, maybe Rajasthan has done this. It is there in their public portal itself, where along with other diseases, they have included type 1 details also. So those models we have started adopting. But of course, the road is long. We need to prioritize this, and we need to make them understand that it's not only the child, it's entire family that suffers.
Okay. So thank you so much. Thank you for giving that hope that, the journey is long, but together we can conquer it. So thank you again. And it is a topic I believe we always feel it is not talked enough. So thank you. Thank you for being here and letting us know your thought. Thank you.
Yes.
Hi, I'm so sorry, I'm stopping the panel right there. I just have one small question.
Yes.
How can we integrate diabetes care in schooling for the patients? Is there a way we can, or if someone could please highlight it, something upon it? Thank you.
All right.
Okay. So I don't think that the number is so big that it can be integrated type 1 diabetes especially in the schools. Yes, definitely in our curriculum we should explain, and they should have basic classification where they explain that what kind of diabetes are there, but I don't think that it is required that type 1 diabetes is not in big number there.
If I can add something, so sorry for chipping. Basically, because there is not many initiative in this area, so there are small baby steps that we are taking. So I thought that will give a lot of motivation. So with UNICEF, we have started developing what we called as NCD responsive school. So in that, we have tried to integrate type 1 with all other NCDs and develop a curriculum. So we are aiming to develop a curriculum which will be designed by kids, approved by technical people and their teachers and school curriculum with education department and with state health department. We are planning to develop something which is something very small booklet kind of a thing which will go into their curriculum. So they'll know that what kind of signs, symptoms and behavioral patterns are there. They will also reduce the stigma, because everybody knows that type 1 kid will have this requirement, and it could be me, my friend or my friend's friend. So those things we have already started, and we are hopeful to see the results quite soon.
The CBSE has come out with sugar boards for educating kids, not just for type 1, but prevention of type 2 as well. There are NGOs like Savitaji's, there are multiple NGOs and multiple projects done by the public side as well as people like Dr. Rutul, Dr. Vipul and myself. What we do is we just go to schools, teach the kids what is healthy, what to do, when to do, how to do. We also take care that we teach them what is healthy abdominal girth, to check whether they have any acanthosis or not. So per se for type 1 diabetes, the care in India is still not that developed. But for type 2 diabetes, now people have started to work at at a major level, wherein prevention of type 2 diabetes or metabolic syndrome in kids has become a very major thing, especially in the secondary and the higher secondary sections.
Thank you very much. Thank you.
Thank you so much. I would request all the panelists and chairperson to have group photo. Dr. Mahira, Dr. Rutul, please join. And then only 2 talks before lunch. Yeah.
Hello, Dr. Rutul, not coming to the picture.
Just a second.
Thank you.
So for the morning session, last symposium, I would like to invite as a chairperson Dr. Pratik Sharma from the team of RIMS, and Dr. Vidisa, a young diabetologist from the city of Ahmedabad, and Dr. Ashok Khatri is joining in 2 to 3 minutes. Over to Dr. Vidisa to invite Dr. Mahindra sir for his talk about beyond BMI. You have to give introduction of Mahindra sir. It's a very long list. He do not require any introduction in India, but still as a part of formal introduction, Dr. Vidisa, please introduce sir.
Good morning everyone, and I would like to invite Dr. Mahendra Narwaria. He's a surgical gastroenterologist, bariatric and robotic surgeon. He's a